Hello, Sam. It's good to speak to you again.
Hello, Steve.
Following our session where we did a role play of a prescribing consultation for students at Plymouth University,
Mm.
I'd like to just reflect on how that went. And what we tried to do was we explained to the students is we didn't rehearse it. We made it as realistic as we possibly could. And I wanted to try and cover all the points that we're expecting people who are learning to be prescribers to cover. Now, we didn't cover them all, but I thought we could reflect on this
Mm.
and both talk about how it went for us, because I'd like to do more. I found it useful. I actually recognised some things that I'd missed as we went along. So if
Yes.
you're looking at this, what we've got on the screen here,
Yeah.
this is what prescribing students are asked to cover. Good communication skills. We've got to build in some theories,
Yeah.
open the consultation nicely, explore the complaint, find out the past medical history, look at the medicines, any other types of history, and close the consultation safely. So is it okay with you if we go through them one by one?
Absolutely. Let's do it because they're very important issues, aren't they?
They are. I mean,
They're
if
important.
you're prescribing a medicine, or really this applies to any clinical consultations, you need to cover all these.
Hmm.
And it might take a long time. We only had 10 minutes. So
Yeah.
I had to refer you to another consultation, which is perfectly, the main thing for patients is you've got, you know what's going to happen next.
Yeah.
Would you say that's
I would say that's absolutely true. Yeah, of course.
so?
What actually lent itself to what made it quite good and gave it a kind of what's the word? A spontaneity was actually the fact that I hadn't absorbed properly you gave me a synopsis of how the interview was going to go and
Yes.
where I was the patient, you were the mental health worker, and I hadn't absorbed all the information properly. But in actual fact, it kind of lent itself to the immediacy and the spontaneity of the thing, because
I
that's exactly
did.
what would happen if one were depressed, because the thoughts are slowed down and I wasn't being accurate with my answers, but in a way, as we noted afterwards, it kind of worked. I don't know whether that's relevant or not.
It is relevant. That's
Oh,
really
okay.
what I'd like to help explore with the students here. So yes, people don't turn up for consultations. Usually you've got an illness of some sort. So it is going to affect what you remember, what you
Of
cover.
course, of
So
course.
the first thing as a prescriber we have to cover is how we communicate. Do you feel safe to talk to us? And one of the things I remember doing was thinking, oh, we're doing this as an online consultation, so I need to ask you if you're in a good place, if it's all working. If you're going to open up to a clinician about whatever's wrong with you, physical health, mental health, whatever, what's important for you, Sam, the first thing or the thing that the prescriber, the person you're seeing, does to make you feel comfortable?
Well, if we're using this format, I would say I need to feel comfortable in my environment.
Yes.
First and foremost, I need to feel comfortable.
Yes.
And Yeah, I need to feel connected with my environment and safe in a safe space. And I
Do you
need to be
think?
able to I need to be able to trust technology, I guess.
Yes.
To trust technology, and I'm a bit of a dinosaur. I mean, I'm only just embracing the digital juggernaut. um, but yeah, I think that's important. To feel the service user to feel comfortable in his own home, as comfortable as possible, and to feel comfortable using what is to those of us who are over 50. It's still kind of a novel thing. My son grew up with it, and it's second nature to him. And to me, it's all every new bit that I learn is absolutely amazing. I still think it's incredible the fact that we can talk like this.
Yes, and you
But,
only
but, but
had
I
10
digress.
minutes.
I digress. But that, yeah,
No, no,
basically,
you only had 10 minutes learning on how to work the system before we did it.
well, well, there is that to it. Yeah, once I've learned it, once you learn it, that's it. It's in there. It's
If you use it all the time.
mm,
Do you think that the clinician, the person you're speaking to, can get across a feeling of empathy and that they're actually listening. Things like eye contact and the posture and that, as we always mention, our sessions are really important. Does
Well,
that work online?
well, the eye contact is there by nature of the fact that I can see you and you can see me, and it's in real time.
Mm-hmm.
So the eye contact issue, which I'm always talking about, and just to digress slightly, I've always told students that, you know, when a service user comes out of hospital and perhaps they go back to their flat, perhaps they go back to a flat that they don't know. Perhaps it's a flat that's been arranged while they've been inside. But for whatever, it's a very stressful time. And, you know, they're waiting for that first visit from their CPN. And eye contact is so important. And as I've said before, there is nothing more awful. There's no more awful feeling for the service user than to see a mental health professional keep glancing at their watch.
So if I was like this, or typing.
Absolutely. If you were shuffling around and kind of looking at bits of paper and looking at your watch, and that tells me that I'm going to die inside, you know. You need to, as I've said before, you need to make the patient feel valued for however much time you've got with them. And in this format, that's good because I can see you, you can see me. I mean, I can't see your feet. I can't always see your hands. I don't know what they're doing. I don't know if they give off signals, but you know.
Interesting. I
mean, you can get up to a point now. You can see that I'm kind of okay. Well, I've got a bit of a growth here, but I'm relatively well scrubbed. I'm okay, and that speaks volumes, maybe.
It does. So you can see quite a lot. That's interesting.
Yeah.
So the next thing is, as a clinician, I have to demonstrate to pass the prescribing course that I'm using theoretical concepts. So when we did the live session for students, I had to make sure, I was thinking really hard, I asked you what your current concern is, and I had to make sure that I'd explored when did it start, how bad is it, have you had it before,
yes,
etc. Did you feel I covered that?
Yes, I think you did. I think you covered it very well.
I put a lot into it. And for if it's a physical complaint like a pain, there are things called mnemonics to help you remember, like OPQRST, which is R is, well, actually, I can't remember the exact details of which is which, but it takes you through the whole body. How did it start? How does it present? Are there anything that makes it better? Are there anything that makes it worse? It's similar things for mental health. So that's a bit we have to, that we've not just sort of skirted over it. We've really thoroughly explored what it is that's worrying the person that we're talking to.
Yes.
So the other thing, and this is what we're told on the course and what works and what doctors say, and I don't know whether you ever watched the program on Channel 4 GP Practice.
I think I did watch it a couple of times. Yeah.
We're told there's a golden minute, that when you see somebody, if you start talking and then I sort of cut in and start talking to you, I'm going to miss what's actually wrong with you. You need to let the user of services or the patient talk for a minute.
Ah, right. Is that because the most important parts of it usually come out in that first minute?
Yes, as long as it's uninterrupted.
Right. So you're going to you as a professional are going to glean the maximum amount within that first minute.
Yeah, so I wanted you to
because it's
feel,
not just the content of what they're saying, but there's other things as well.
Is there anything else? And I wanted you to feel that I was letting you talk. Because if I'd have come in earlier and said, "Oh, that sounds like such and such," I might have stopped you saying something.
Of course.
Additionally.
Yes.
Did you feel this was covered? Did you feel in that role?
Yes. Yeah.
There's another way of explaining it. Another thing about consultation skills that I tried to get across, and I don't think I covered all of it as thoroughly as you can, is I need to find out what your ideas are. So whatever sort of illnesses have, whatever it is, and it's often not just one thing. What are your ideas? What do you think it might be? What are your concerns? What's worrying you? And we certainly, in your case, in the scenario, it was about you were feeling really depressed. To the point that you were worried.
Yes.
About your safety.
Yes.
And then also what your, as throughout the consultation, what are your expectations of the consultation? I'm not sure I covered that as thorough as I could. So it's called ICE, people's ideas, their concerns, their expectations.
Right. Okay.
The next bit, this is relating, I'll talk to the course, is exploring the presenting complaint. And this is where we touched on it earlier about what exactly it is, how bad it is, have you had it before, what have you taken for it before, and did you think, bearing in mind the scenario with somebody with depression, you were somebody with depression, did you think I was getting to the bottom of what was concerning you?
Yes, I think you were getting there. Yeah.
Your role play was very good.
Oh yeah, I was. I mean, I was making it so that my, for want of a better word, character was finding it difficult.
Yeah.
You know, to kind of articulate it.
Yeah.
As well as the fact that I was struggling with trying to remember it.
Which is what happens. Yeah.
Yeah. I made him so that it was difficult for him to get it all out, because I remember back when I was severely depressed, how difficult it was to get everything out. And always 99% of the time when you finish your consultation, and back in that day, we didn't have this, you had to physically be there with the doctor. 99% of the times you would come out and go, oh my God, why didn't I say this? Oh my God, why didn't I say that? Why didn't I say this? Why didn't I say that? A load of stuff. So there must to be techniques for winkling that out of the person, I think. Especially, it can be seen if somebody's holding back, then the mental health professional should be able to tell that there's more to come.
And we should be using sort of open questions. And then when you're talking about something a bit specific, when you talk about suicide, I start to ask you more questions about how suicidal you felt. Had you felt like it before? Did you feel like harming yourself? Which is called a red flag in terms of the course. It's something where you need to take specific action. It's potentially urgent. Yeah. And then later in the consultation, which I don't think I covered as much as I should, is reflect back what you've said, just to make sure that we've understood each other.
Mm-hmm.
And there are red flags, very important, especially for this course and in life, in any consultation, because in mental health, it could be suicide risk. In physical health, it could be worries about sepsis, which is hard to spot. It could be worries about reactions to medication. It could be that you present with something that appears simple and it isn't. Cardiac asthma is an example. Sometimes people who, and this has actually happened to a relative of mine, appear to have asthma, but actually it's caused by a heart problem. Other things that students mentioned was are there any safeguarding issues? Is there something unsafe about where you're living or the people you're living with? So all these red flags we need to bring out in the presenting complaint.
Mm-hmm.
We went on to look at the past medical history. And the key thing about this, although very often in consultations, or a lot of the time you would have the history in front of you, it's something you've always got to go through. And the important point from teaching on the course is I needed to go through with you all the systems of the body to make sure that there wasn't a physical cause for what was happening to you and there wasn't something else going on. And there's various mnemonics you can use for that. And I always think of it in terms of top to toe. Look at mental health, look at sort of going down the body. Have you had any problems with your heart? Have you had any problems with your breathing, etc.? That was what I tried to cover. Do you think that was brought out?
Yes. Yeah, it just occurred to me though, I wonder if somebody's been on all sorts of medications, which I have, going back to the original olanzapine, which were like massive. They were like huge. And over 20 years ago when I first started taking those, and the side effects were awful, and which is one of the reasons I remember them so well. And now I might say that olanzapine, they've refined it. Whoever it is that makes them, they've refined it. So, I mean, they're so good now. There's next to no side effects, and they're great. The only side effect you get is that food tastes absolutely wonderful. Even lettuce tastes gorgeous. Your brain is telling you to eat, I suppose. No, what I was going to say, how many service users would be able to remember what drugs they've been on? Because I certainly can't. I can't remember everything I've been on. Been on so many, I would never be able to remember them. Not all of them, because they kept changing. And also, how many are going to be out of the medicines that they have taken? Let's be honest, it's a fact of life. Medications aren't always consumed. I consume mine now because I know I need them. But I'll admit to you, there have been times when I've been in hospital and out of hospital where I haven't taken them. And I've told the professionals that I've been taking them, but I haven't. And even times when I've been in hospital where I've taken them, I turn my back and I spit them out.
Yes.
And they go behind the little pipe in the toilet or whatever to build up.
And that's where the past medical history and the medicines history, that's where they sort of link together. So
yeah,
I was looking to see what other consultants or clinicians you see. Have you got any other illnesses like asthma, etc.? And moving on to medicines, and it's so important. This is very much, people have to cover this.
Yeah. I mean, the issue is that person was prescribed those medicines at the time, irrespective of whether they actually ended up taking them or not. Those were the ones that were prescribed. But are they going to remember? I mean, I've been under the mental health for, I don't know how many years. It must be close to, well, it's over 25 years. You know, but there are some 25-year-olds who are just kind of entering it. And there are hundreds who have slipped through the net or have slipped through the net for a good 15, 20 years before they are, I don't want to say caught, but let's say caught up with and persuaded
hopefully
to go to hospital
the good
on
way.
Section 2. Because if they don't, they're going to get forced to go in anyway, but that's another story. But yeah, that's a difficult one, really.
So on the medicines, from the point of view of a consultation, if you're describing it, you would hope that clinicians would have a full record of all the medicines that you've ever had prescribed.
Yes.
It's not always the case, and what they were prescribed for.
Yeah.
So we need to ask you what's prescribed at the moment. What have you had in the last 3 months? And then we need to talk about medicines that you might buy over the counter, herbal medicines, food supplements, vitamins. We discussed that. You're in the scenario, you were taking St. John's wort. Now, you might not have thought that was a medicine if I hadn't said, have you ever taken any herbal medicines?
Yeah.
And paint a picture of everything, not just medicines that are prescribed. Also, borrowed medicines. If you borrow from your neighbour, it's not that uncommon.
No, of course not. Medicines that they can get off the
Anybody
internet.
could have done it. Medicines that are bought over the internet, that's extremely common. Some people might not think that's relevant or might not want to say it, but we'd rather know than not know. Street drugs, smoking.
I was going to say street drugs, very important.
Alcohol. Diet's also important. In the medicines history, what's vitally important, and from the point of view of the course, I need to stress this, is asking you about allergies and sensitivities. And I thought straight away after I'd finished the consultation, I asked you about allergies. I didn't specifically ask you about sensitivities. And actually in your scenario details, you were sensitive. You were elastoplast, caused a rash.
Yes. Oh, that's
I never specifically asked you, so it's very important to cover. Have you ever reacted badly to a medicine? If you're allergic to it, what actually happened, etc. So it's a very complex area, and I would say in that consultation, my critique of myself is I didn't cover allergies and sensitivities as thoroughly as I should have done. And you certainly need to be very specific with people.
Excuse me.
Next bit, there were other things. It's not just the medicines you've taken, but there are other things, aren't there, that can be relevant. For example, have you taken any? Your social history, your housing? Sorry, I lost my thread for a second. Then if it's a female gynecology, obstetric history, sexual history.
Mm-hmm. These are all relevant.
Yes,
Mm.
building a picture of people's lifestyle, risk-taking history, family history, etc. We are students. We want students to be clear about that and to relate it to the area of. So, for example, if you come to me with a lung condition or a bad cough, I would want to ask about your employment.
Mm-hmm.
Had you worked with anything that might have caused chest problems, asbestos,
Chemicals,
other chemicals, anything like that?
Mm.
And of course, nowadays, we need to ask about foreign travel and COVID. I didn't cover it in what I
Yes.
talked to you. The scenario is that had been covered before I spoke to you. So from the point of view of mental health, what are the sort of things that really make a difference? When we talk about housing, social situation.
Well, housing makes an enormous difference. I mean, it's at the risk of repeating myself, you know, to feel comfortable in your environment is hugely important. It's very important. I mean,
Yes.
but there is the issue of this is a strange one, and I'll give you an example that has happened to me twice, at least twice, where I've left my flat to go into hospital, and I've spent quite some time in hospital, and then I've been discharged with a care plan, you know, with the promise they'll come and visit me, I think every day to begin with, and then twice a week, then once a week, whatever it is. And you come out of hospital, and then you get back to your flat, and you open the door, and you close the door behind you, and then you sit down, and it's like, okay, now I'm here. What's next? And you're just staring at the four walls, and there's no buzzer going. Nobody's making you foods. Nobody's telling you to go to bed. That can be stressful, very stressful. When a person goes back, I don't know if this answers your question at all.
It does. It's about things other than medicines that will affect how you.
But that was always, and I remember one time coming out of hospital and absolutely dreading going back to this flat in the Elephant and Castle in South London. Mainly, without going into detail, but mainly because of what things that had happened in and around that flat. And I just didn't want to go back, but I couldn't admit to them that I wanted to stay in hospital. My pride wouldn't let me do it. But I'd rather have stayed in a hospital. And of course, I went back to my flat, and it was absolutely awful. I closed the door behind me, and of course I didn't sleep for 3 days, and I stopped taking my meds, and I stayed out of the flat until it was time for them to come and visit me. And I'd go back into the flat about 10 minutes before they were due to turn up, and they'd come, and I'd make all the right noises and get through it, and then they'd leave, and I'd go because I'd hated it. That was absolutely awful. I remember, that was in the Elephant and Castle. How I got out of that was I changed my environment completely, and I got rid of all associations of the person that was there with me before. And it gradually got easier. But not only is it difficult to adapt, to come out of hospital, to go back into your flat, or perhaps a new flat, perhaps a flat that you've been waiting for, that they've got for you. So you can come out of hospital, you go back into it. That's a very stressful time. But even if it's a flat that you've had for years, that can be awful because of what's happened in that flat. I got in there, and immediately I relived all the madness and all the hell that was happening in there, and it was bad. And these issues are very they're relevant.
As important as medicines.
Well, yes, yeah.
Like you say, the medicines won't help you if you need them, and also you might stop taking them because you feel so low and isolated.
Either you feel so low that you don't believe anything that you take could possibly make you better,
So that's
well enough quickly, because you want to get well now. You want to feel different now. You want to be in a different headspace right now. And you tell yourself, anything that I take, it's going to take weeks. It's going to take weeks before it even kicks in. And, and that's one of the many reasons that a person may not take their meds.
Yes. So looking at, sorry.
Carry on.
So looking at the last bit, bearing in mind, in this consultation, one of the things I did was said I needed to speak to you more, which is perfectly legitimate if you've only got a short time slot. But how did you feel about that? Were you going to be there when I spoke to you? Did you think I'd given you some sort of adequate follow-up?
Yes, I do. Yes. Yeah.
Because
maybe it's tied in with the fact that I know you anyway, and I've known you for years. I mean, I tried to separate myself from that, and I tried to put myself in the role. But yeah, I think that was adequate. Yeah.
I think
you instilled confidence in me, and there was a warmth that came across, and I think those things are very important. That's all linked up. That's all linked up with eye contact, making the service user feel valued. That's very important, because if you don't feel valued, that's terrifying. It's awful. It's frightening. You're just going to feel like a statistic, another number.
Yes.
So as I've said before, eye contact, listening, trying to be warm, being friendly, not glancing at the watch all the time, or shuffling papers, or taking phone calls. When the phone goes off, that's awful. Make a point of switching the phone off, or have it on silent, because you're dealing with somebody's deepest, darkest, sometimes, things that they carry around with them on a daily basis, and now they've got to bring it to the fore. They're going to feel very raw, and there's only, let's face it, sometimes there's only 15-20 minutes. So you've got to get that person into a state of mind where, firstly, he feels able to,
no distractions.
That's an enormous skill in its own, on its own.
Part of the preparation.
Suddenly, if that's broken,
I left the phone on by mistake.
Absolutely. And now, if the flow is broken by a phone going off, or you're looking at your watch, what does that tell me? Me as the service user, it tells me, oh, it's not just me. He's got other clients. He's got more important stuff to deal with. He's looking at his watch. He wants to go home and have his dinner. He can't wait to get away from me. I'm just a statistic. I'm an irritant.
And if you're feeling bad about yourself,
I'm bottom of the food chain. Oh dear. Yeah. And then when you've gone, I'll be really depressed, perhaps suicidally. Who knows?
And that's why in closure we need to make sure there's some sort of agreed plan, and we know we're going to follow up on it.
Absolutely. Yeah. That leads onto it, an agreed plan during the closure.
There's some sort of safety net as well, because I talked about helplines and things.
Yeah.
And I even included the Samaritans, that you're signposted to services that might help you, and that any referrals are made.
Yeah, signposted to relevant services. And the closure part of the meeting should leave them feeling that they can phone you at any time, or phone a person at any time. They've got that, and that they've got a phone with credit on it that they can use.
Very good point.
Yeah, I mean, that's up to them, but
it's something to ask. Have you got credit?
To leave them, if they're left feeling that they've strengthened the bond, that the bond has been strengthened between service user and mental health worker, and each time they come, it's been strengthened. That they can call you anytime they like, and as you say, they know there is a follow-up plan. They know where they're going to go from now.
Yeah.
Until the next meeting. Yeah. And they'll have that in the back of their mind.
So that really is what we were aiming to do. We'll have to do some more of these.
Yes, they're great. I'm up for it.
I've asked students for feedback, and I've given them a link to give some feedback as well. Mm-hmm. So these are all the components of a consultation that are on the screen here.
Mm-hmm.
And thank you for that, Sam. Is there anything else?
You're welcome.
I will make this into a little vlog, and we'll share it out with the students, if that's okay.
Oh, good. I hope they enjoy it.
Thank you. Thank you
Thank
very
you.
much.